Welcome to this explainer. Today, we're taking some pretty dense clinical data and translating it into what is, honestly, a high-stakes journey right through the biological battlefield of acute respiratory distress syndrome. You probably know it as ARDS. This is a terrifying condition where a patient's lungs literally become the site of a massive, life-threatening inflammatory war. We're going to break down the exact mechanics of the syndrome. We'll go all the way from the microscopic damage happening deep down in the alveoli, right up to the extreme, desperate bedside strategies doctors use to keep these patients alive. So here's our roadmap for this logical journey. 1. Defining the respiratory crisis. 2. Direct versus indirect lung injury. 3. The 3 phases of ARDS. 4. Diagnosing the true culprit. 5. Strategies for lung survival. And finally, 6. The long road to recovery. All right, let's jump right into section 1, defining the respiratory crisis. We really need to trace how our medical understanding of this devastating lung failure has evolved, because it's moved fast. Back in 1967, Ashbaugh and his team first described this in 12 patients who had this profound, totally oxygen-resistant respiratory failure. Then, jump to 1994, the AECC gave us standard oxygen ratios, but honestly, it lacked a specific time frame. The 2012 Berlin definition fixed that. It established a strict 1-week time frame and categorized the severity into mild, moderate, and severe. But here's the catch. Berlin was basically designed for well-resourced hospitals. That's why the 2024 new global definition is such a massive game changer. It's a total paradigm shift. It actually allows doctors to use things like pulse oximetry, high-flow nasal oxygen, and bedside ultrasound. The so what here is that we can identify that underlying inflammatory injury much, much earlier, even in hospitals that don't have infinite resources.
Moving on to section 2, direct versus indirect lung injury.
Okay, so how does this damage actually start? Well, there's a really important dichotomy between two completely different paths that lead to total alveolar failure. The crucial thing to understand is that ARDS isn't always caused by a direct lung infection. I mean, sure, direct insults like a severe viral pneumonia or, aspirating gastric contents, those absolutely burn the lungs from the inside. But sometimes a systemic crisis, like sepsis from an intra-abdominal abscess or acute pancreatitis, basically forces the immune system into total overdrive. In these indirect cases, the lungs are essentially just innocent bystanders. They are friendly fire casualties caught right in the middle of a massive systemic cytokine storm. And there's a really stark contrast between these two mechanisms. With direct injuries, like pneumonia, the assault is right on the alveolar epithelium itself. This often shows up as asymmetric, patchy consolidations. But indirect injuries, they actually target the vascular endothelium through the bloodstream. The damage is coming from the blood vessels feeding the lungs, which usually results in these symmetric, dependent opacities. Recognizing this difference is absolutely paramount for clinicians because, well, these two subtypes act totally differently on a biological level. Let's zoom in on the molecular battlefield itself in section 3, the 3 phases of ARDS. This is where we walk through the terrifying, escalating phases of the syndrome, watching the lungs transform from a massive inflammatory fluid leak into chronic, unyielding scar tissue. First up is step 1, the exudative phase, usually days 1 through 7. The alveolar barriers completely break down. Macrophages release these potent inflammatory cytokines, which draw neutrophils, and those release reactive oxygen species. It creates this thick, protein-rich fluid that just floods the lungs. Then we hit step 2, the proliferative phase, around days 7 to 14. This is the body's frantic attempts to fix things. Type 2 pneumocytes multiply rapidly to rebuild that delicate lining. Now, if the body wins here, the fluid gets reabsorbed. But if it doesn't, we cross into step 3, the fibrotic phase. Extensive collagen gets deposited, the lungs become incredibly stiff, like scar tissue, leading to permanent pulmonary hypertension and really severe chronic failure. Now, here is the really tragic irony of ARDS. The mechanical ventilation that is literally keeping the patient alive, it can actually make the biology worse. This is known as VILI, or ventilator-induced lung injury. Think about the mechanical stress, the repetitive snapping open and closing of collapsed alveoli, or the really high airway pressures. That physical stress triggers a biological cascade called biotrauma. The lungs end up releasing even more inflammatory mediators into the bloodstream. This creates what we call organ crosstalk, which means this localized lung injury can actually trigger multiple organ dysfunction in completely separate parts of the body. We're talking catastrophic damage to the kidneys and the liver. Which brings us to section 4, diagnosing the true culprit. With a patient's breathing failing rapidly and that threat of biotrauma hanging over everything, the medical detective work has to start instantly. This is arguably the most critical question for any clinician looking at a patient struggling for air. Is it actually ARDS, or is a clever, non-supportive mimic responsible? We have to know, because if it is a mimic, the standard supportive treatments for ARDS simply won't save them. To solve this mystery, doctors have to systematically rule out the imposters. Take cardiogenic pulmonary edema, for example, which is basically heart failure. It floods the lungs with fluid, exactly like ARDS. But you'll see an elevated jugular venous pulse and a really rapid response to diuretics. We'd confirm that with an echocardiogram. Then there's diffuse alveolar hemorrhage. This is where the patient is literally bleeding into their own lungs. Doctors catch this by looking for bloody fluid during a bronchoalveolar lavage. Or what about acute eosinophilic pneumonia? That one actually responds dramatically to steroids. Accurately identifying these mimics isn't just an academic exercise. It's an absolutely life-saving step. All right, Section 5, Strategies for Lung Survival. Once ARDS is definitively confirmed, and we know for sure the mimics are ruled out, we enter the most critical phase. This is where we deploy extreme physical and mechanical countermeasures. The whole strategy immediately shifts to gentle mechanics. We use lung protective ventilation, targeting tiny tidal volumes, just 6 milliliters per kilogram. Why so small? To protect what we call the baby lung. That's the tiny fraction of lung tissue that's actually still aerated and functional. We also use PEEP, or positive end expiratory pressure, to keep those alveoli from collapsing at the end of every single breath. When that isn't enough, we physically flip the patient onto their stomach, prone positioning, for at least 16 hours a day. This takes the crushing weight of the heart and abdomen right off the lungs. And in the most extreme refractory cases, we bring in VV ECMO. It's literally a machine that bypasses the lungs entirely to oxygenate the blood outside the body. But listen, if an infection, something like sepsis, is driving the ARDS, all the high-tech ventilators in the world won't matter if we don't achieve source control. And there is a terrifying, absolute ticking clock on this. Surgical data shows that achieving source control, meaning physically eliminating the source of the infection within 6 hours, reduces 90-day mortality by a massive 29%. Watch how fast this risk escalates. If you miss that golden 6-hour window, the absolute risk of death just relentlessly climbs. Delaying to 12 hours, that increases the absolute mortality risk by 1%. Delaying to 24 hours pushes it up by 3%. And by 36 hours, you're looking at a 5% increase in absolute mortality risk. Every single hour of delay in the operating room literally translates to lung tissue dying in the ICU. Finally, we reach Section 6, the long road to recovery. We have to look at the grim reality of what happens if a patient actually manages to survive this acute biological battlefield. Surviving ARDS leaves profound physical and mental scars. During the acute phase alone, up to 15% of patients suffer a pneumothorax, which is a collapsed lung caused by the ventilator pressure. Acute kidney injury hits nearly a third of patients, and that spikes the mortality rate to almost 60%. And even after they finally leave the hospital, the burden is massive. Survivors deal with persistent skeletal muscle weakness, severe cognitive deficits, and incredibly debilitating psychiatric disorders like depression and PTSD. The acute war might be over, but the rebuilding, that takes years. So as we reflect on this 2024 global shift toward earlier detection, we are left with a really critical question. Knowing that timing is absolutely everything, from that frantic 6-hour source control window to stopping the inflammatory cascade before the fibrotic phase permanently sets in, will catching this silent killer faster with inclusive tools like bedside ultrasound and pulse oximetry finally give us the permanent upper hand against ARDS? It's a question the medical community is actively fighting to answer right now. Thank you so much for joining me on this explainer, and as always, keep questioning the science around you.